Welcome to the Good.Enough.Shrink podcast. We are your hosts. I am Jenna Chang, a child, adolescent, and adult psychiatrist practicing here in Los Angeles, California.
And I'm Dr. Patrick Kelly. I am also a child, adolescent, and adult psychiatrist practicing in the Los Angeles area.
We are on a mission to demystify child psychiatry and have conversations surrounding difficult topics on youth and adult mental health, but not without a little play along the way. Welcome back to the podcast. So today is a special day because it marks the 1-year anniversary of this podcast, Good.Enough.Shrink. We started last year on July 23rd, and this year we're starting the new season with a bang on the topic of electroconvulsive therapy. Now, this is a controversial topic in some areas of the country and the world, and in other areas of the world, it is completely accepted and widely used. So we want to give you information that's accurate and nuanced so that you can make the best decision for yourself or your family members. So let's get right into it. So ECT has a pretty long history of stigma with portrayals that really bear little resemblance to the actual procedure today. The stigma came with media portrayals, especially like the One Flew Over the Cuckoo's Nest, that really changed the discourse around ECT. And yet it has shown to be one of the most effective and safe and life-saving treatments for severe depression, bipolar disorder, schizophrenia, and other psychiatric conditions.
I couldn't agree more. I think that One Flew Over the Cuckoo's Nest is a really good example of the sort of merging of worlds, because in that movie, ECT is pretty much used as a punishment for patients who are acting out or being naughty. It's really a behavioral modification technique. It's similar to the idea of if someone's being rude or behaviorally out of control, we're going to perform surgery on them without anesthesia. We're going to cut you open and look at your organs when you're wide awake. That is the portrayal equivalently of ECT without anesthesia in One Flew Over the Cuckoo's Nest. It's cruel, it's inhumane, but real ECT is nothing like that. I think people have this image of what they see when they think of electroconvulsive therapy, of someone being wheeled into a room, yelling, screaming, a mean person puts electrodes on the side of their head. It's extremely painful. None of that happened. 0% of that is accurate. So it's really using a very low voltage, mild electrical stimulus to induce a central seizure in the brain that the body's pretty much unaware of for the most part, that is used as treatment, not as behavioral modification for the underlying diagnosis. I think that's important to put into context.
So important. I remember the very first time I saw ECT treatment as a medical student, and it was almost like that was it. There's a little bit of toe twitch, and the patient is asleep, comfortable, lying down, took a minute or so, and that's it.
Yep.
So starting off with the definition, what is ECT? ECT is a brief electrical stimulation of the brain while the patient is closely monitored under general anesthesia, and it induces a seizure. The seizure lasts anywhere between 20 seconds to 1 minute, and the length of the whole thing from going to sleep to waking up is about 10 minutes.
So we talk about the seizure, and people have an image of what a seizure looks like, right? Somebody falls to the ground, they're shaking uncontrollably, their eyes roll back in their head. That is not the type of seizure that we're talking about. When you're under this type of anesthesia, not only are you asleep and totally unaware of what's happening, but your body is in a deeply relaxed state, so there is no peripheral seizure. They use a special technique to make one part of the body respond so that they can visually monitor the hand or the foot. But in general, you don't get the same muscle tightening, you don't get injuries, you don't feel it, they don't remember it, this is not painful for the person. There is this idea of ECT as this monstrous, barbaric thing that's simply outdated and not true.
Yeah. there is a history of ECT too that's important to recognize. So back in 1938, Ugo Cerletti, who was a neurologist in Italy, and Lucio Bini, who was a psychiatrist in Italy as well, they developed the very first ECT procedure. And they were actually nominated for the Nobel Prize for this life-saving procedures. But at that time, they administered much stronger currents that we do not use today. It was one of the somatotherapies that they called in the 30s, along with insulin therapy and lobotomy, which have been completely disproved today. And so modern ECT is mild, very brief, controlled seizure, and they use muscle relaxants to prevent the seizure from spreading to the rest of the body. Really, all you see is a foot twitch or a finger twitch. We work closely with anesthesiologists who are specifically trained to work with any sort of procedure that requires general anesthesia. So you've got two physicians who specialize in what they do. So it's a very safe and effective procedure today.
One of the real revelations that I had about that was also during medical school when the ECT chief of service told us that this is the treatment of choice for severe depression in patients who are pregnant, because medications affect the developing fetus much more so than the electrical stimuli, which does stay in the brain and doesn't spread. Considering what I always thought of ECT sounded wild, but is true. This, in a way, can be safer than some medications, and it can be the treatment of choice because it's so effective and safe. We're talking mostly about ECT in general terms, but of course, we're child and adolescent psychiatrists. And so in children or adolescents, ECT is even more highly regulated and even more controversial, even though it's been around for a long time, almost since ECT was first trialed in the early 1940s by Dr. Boer-Heuer, who was treating teenagers in France. And actually later on, Dr. Bender published a case series of 98 children with what he described as childhood schizophrenia, who received a total of 20 treatments and actually experienced substantial improvement. More recently, people have looked more intensely at the idea of ECT for children and adolescents because there's been an increased recognition that just like adults, children can unfortunately be very ill. So would this treatment be as effective as it is for adults? And it seems to be. So the American Academy of Child and Adolescent Psychiatry in 2004 came out with practice guidelines for electroconvulsive therapy in children and adolescents. And it remained somewhat divisive in the opinion. Actually, a survey that came out in 2001 of child and adolescent psychiatrists showed that 53% of providers had minimal knowledge about the use of ECT in adolescents. 75% said that they lack confidence or skill in even providing a second opinion about ECT. And about half believe that ECT could be unsafe in children. But a little bit later on, and it takes a while for these things to happen, but the ethics committee of ACAP in 2012 published a pretty expansive report about the ethical considerations and safety and efficacy for electroconvulsive therapy in children and adolescents, and did find that it was a safe and effective treatment. And even more recently, a 20-year study on children and adolescents, a huge study, showed that there were no negative cognitive effects for patients who had electroconvulsive therapy. That's one of the other concerns is, are we robbing Peter to pay Paul? Are we treating the underlying psychiatric condition at the expense of cognitive development or memory, especially in the developing brain? And it seems like we're not. That there weren't any negative cognitive effects to the treatment. Whereas, admittedly, we know that depression can cause cognitive decline. So there are positive outcomes for ECT in the child and adolescent population that, similar to adults, really outweigh a lot of the concerns. Again, not to be casual about a treatment like this, but to say that many of the barriers that we foresee about the utilization in young people really aren't founded in evidence.
Yeah, that's really well said. That's one of the biggest things we worry about is memory, cognition, attention being affected by an induced seizure, right? But that doesn't seem to be the case. That's not shown in long-term evidence.
So why ECT over other treatments is the big question. It is for treatment-resistant conditions, treatment-resistant depression, bipolar disorder, psychosis. That's technically failing 2 medication trials. And there are different ways that ECT has been really helpful on the mood side of things, whether it's depression or mania or bipolar disorder. But there's also when a child with autism is violently attacking themselves over and over, causing serious self-injury, and you see things from broken noses to detached retinas to repetitive concussions, and no amount of medication works. ECT can be life-saving in these cases with minimal side effects because it's not a medication that can cause a lot of weight gain, diabetes, or other adverse effects. So it is an important consideration in children.
And that's a really important point because it brings up the idea of, are we using ECT to teach children not to hurt themselves? If you hurt yourself, you're going to get this shock. And there's a psychiatrist at the Kennedy Krieger Institute in Baltimore, Lee Wachtel, who's really made her career out of answering these sorts of questions. And the repetitive severe self-injury associated with autism seems to have a biological basis because even when someone is under anesthesia, has no memory of the procedure, ECT really significantly reduces repetitive self-injury. There was a journal article about 10 years ago in the American Journal of Psychiatry showing exactly that, a large study of kids who were doing very severe injuries to themselves, where this treatment could absolutely be seen as life-saving. And there are examples of the balance of restrictions on ECT and the contrast with the fact that for some patients, it is not only the treatment of choice, but the only treatment that has a chance of really alleviating these conditions. In severe catatonia, somebody can't move, can't speak, can't feed themselves, can't meet their own needs, and if left to their own devices, would starve to death or expire. So, I mean, life saving is not an exaggeration for some of these families and people who are going through these trials. And yet, in the interest of trying to protect patients, laws and regulations exist around this so as to make access to this treatment essentially impossible in some areas.
Right, which brings up a very important point of discussion, which is access to ECT varies significantly based on what state you're in. So there is no U.S. national law on ECT. There's no federal law. So it leaves the individual state governments to regulate this treatment. And some states have descriptions in their laws pertaining to ECT, like who can perform ECT, who can give informed consent. But most of them have no laws at all. They make no comment at all on ECT, which brings up a lot of ethical discussions and the requirements surrounding pre-procedure and post-procedure. So we are practicing in the state of California, but just, for listeners out there who might be listening from out of state or other parts of the world, it's really important to dig into the laws in your local area. I have to say that it's really hard to find specific information. So you might have to talk to people who are specialists, lawyers, physicians to get specific information. In California, any adult age 18 or older with appropriate diagnosis can give voluntary informed consent. Under the state law, they do not allow ECT to be performed for a minor under the age of 12. And this is a hard statement that they make. And for minors between the ages of 12 to 16, it becomes a little bit gray and possible. So the first thing is that it has to be an emergency situation that is life-saving. So as Dr. Kelly was saying, not eating, not sleeping, it really is affecting their ability to sustain life.
And I'm no lawyer, but I do know that emergency situation and life-saving are actually not defined. So that language is used, that it has to be an emergency situation, and ECT must be designated as a life-saving treatment. But who can make that designation and who can define what an emergency is and what is life-saving is actually not defined anywhere. So it becomes a little bit capricious and at the will of whoever is reviewing the laws at the time to make those decisions of designations in the moment.
That's a very important point. It has to be reviewed and approved by 3 psychiatrists. So it's 2 psychiatrists who are board certified, and 1 psychiatrist can be board eligible. These are psychiatrists that are appointed by the local health director, administrator. And so I trained in Pennsylvania, and there the law was that you need 2 psychiatrists. The second psychiatrist was the one doing the ECT. And so it was more like an ECT evaluation. So it's quite different trying to get 3 psychiatrists together versus 2. Also, there's a lot of differences in the involvement of the courts, especially when someone is very, very ill and they need involuntary treatment. We talk about this in medicine quite a bit of autonomy versus beneficence. And it brings up discussions about what does it mean to have rights, who can make informed decisions. So I think that's also part of the reason that there's stigma surrounding ECT, because it brings up a lot of challenging ethical questions about who can make decisions about their body.
And you do bring up an important point that a lot of times this is done quote unquote voluntarily, but we've already talked about that some patients are catatonic. They can't speak. They can't fully understand what's going on around them. And so who is their surrogate decision maker? Who is able to decide for them? And it would seem obvious that for a lot of these cases, it would be the parents, especially if we're talking about children and adolescents. But even that becomes complicated because you have to go before the court to actually have the parents designated as an alternate decision maker because of the weight of this decision to watch out for the patient's rights, with on the surface sounds like a very good idea. It's protecting the patient. It's another layer of check and balance, but it results in delay of care, and it results in additional barriers being put in place for families, patients, psychiatrists who really want to help, but going before a court, going before a judge who's never heard of ECT, who needs this all explained, who themselves have to determine if it's an emergency situation and life-saving. They have to sort of make that up on the fly, whether it meets that criteria. It's a huge, involved process that gets in the way of access to care, particularly for patients who may have less access to attorneys or to psychiatrists. So it becomes sort of a socioeconomic equity question as well for patients who may not be able to push through the court system to get the same level of treatment.
And I'm now thinking too about being the judge in that situation or the attorney. It is hard when we don't even know exactly the mechanism of ECT. I mean, we have some ideas that it can affect neurotransmitters, GABA, glutamate. GABA is the main sort of inhibitory neurotransmitter in the brain. Glutamate is the main activating neurotransmitter in the brain. And ECT seems to do some sort of reset of the brain. But, when it's vague and it's unclear, and the research in ECT is not greatly funded because of the stigma, we're stuck between a rock and a hard place. So I think it's challenging when science hasn't caught up to what's needed more immediately clinically. And some of that also has to do with special interest groups that are very much against this. And this is a place that we make a strong stance that we support ECT and we fully believe in the effectiveness and the safety of the treatment. However, there are people who genuinely feel that it has long-term harmfulness. There's stories that are important to hear, and yet it takes away the opportunity to have a life-saving treatment for others. And so it's a very narrow version of the story for people who are very much against this treatment.
Absolutely true. And I think that's a very important point, that the evidence we do have doesn't back up the claims that this is a very dangerous treatment, that this can be a harmful treatment. We know the evidence does weigh in the other direction, but just like taking an aspirin can have side effects, there are people who will report that they've had a negative effect from ECT, and those individual instances are sometimes taken out and hyperbolized and overgeneralized to represent ECT for everyone who could ever have it.
Mm-hmm. And I think there's something to be said about the strength of stories when things are told in a certain story with emotions attached and background and all of that, the contextual way that stories are formed. It's very powerful. All the more reasons that we want to share stories of hope and recovery and stability with ECT. And so one of those stories is actually this paper that our esteemed colleague, Dr. Michael Kaus and Dr. Patrick Kelly himself published recently that we will talk about.
This is a big topic. I think the power of stories is important, and I would love for people who are listening to come back for part 2 of our discussion about ECT, where we'll interview Dr. Kaus himself and talk to somebody who's really worked in treating one of these patients that we're discussing and has firsthand knowledge of trying to navigate the system, making a diagnosis, and getting somebody the treatment that is clearly indicated, and the 3 months that passed in between. I think the positive side is that people are starting to get more of the stories of recovery and improvement out there, that there are more and more cases being published in the academic literature, and there's more and more advocacy at various levels for increasing access to this treatment. I know that in the state of Idaho, a bill was just approved by the House committee to allow ECT to be approved for children in the case of a severe mental illness, similar to the California bill, and has been signed by the governor. And in Colorado, another similar bill has been introduced. So there is forward movement in increasing access to ECT and recognition of the positive improvements that can be made. But I think people are understandably cautious about moving too quickly in any direction. So I think the best thing we can do is share the stories that we have and the evidence that we have of how helpful ECT can be and how detrimental the barriers to getting ECT are.
Yes. So tune in next time for a detailed story of one of these cases that we would love to share with you.